following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, headaches. Two experts are here to answer your questions. Now here's your host, Dr. John Phillips.
Good evening. More than 45 million Americans have some form of chronic headaches, and more than half of them suffer from migraines. But whether it's a chronic condition or occasional pain, you don't have to live with it. What kind of headache do you have? When is a headache a sign of something more serious? What are your treatment options? We'll get answers to those questions and more tonight from our two guests, Dr. David Watson, a neurologist at WVU and medical director of the WVU Headache Center, and Dr. Lori Gutman, also a neurologist at WVU, whose special interests include neuromuscular diseases. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. David, we'll start with you. We have lots, there are many different types of headache. How can you tell what type of headache a particular patient is having?
Well, the biggest thing to think about is really just the history of how the symptoms progress. We think about a variety of different types of headaches. Most commonly, we see patients with migraine, but there's tension headaches and cluster headaches, and then certainly headaches that are a sign of something worse. The most important part is really the patient's story of the headache. Once we get that story, then there are a lot of tests that we can do if needed, although oftentimes there's not much that we really need to do beyond the history. But sometimes people need scans and sometimes blood work. So it can be a long process to sort out, but sometimes the history will tell us everything we need to know.
Okay, good. And Lori, headaches it may just be a sign of a more serious health problem.
It can be a sign of a more serious health problem, or it can be a sign of a completely different health problem than you might expect. So you might go to the doctor thinking that you have a headache and it might be a migraine, and it turns out that it's a sign of something else going on in your body. Sometimes people get headaches from arthritis. Sometimes people get headaches from more systemic illnesses, and sometimes it can be a sign of another process, including more serious things such as brain tumors. Uncommonly, it can be a sign of stroke, usually a bleeding stroke. But when you're trying to, again, this goes back to what David was saying, when you're trying to figure out what's going on with the patient and the cause of the headache, the history is going to tell you whether this is something that's coming as just a primary headache or whether it's a secondary headache, so coming from something else. Okay.
So as I mentioned at the start of the show, it's very common. When is having a headache an emergency? When should someone seek immediate care for a headache?
Probably the most important thing is if you have a headache that you've never had before, if you have a headache that's different than any headache that you've ever had before, and especially a severe headache, that would be one where you'd want to seek care. If you have a headache that causes you to have some other symptom with it, like you have a headache and then you pass out for the first time, and you have a headache and you have a seizure, or you notice numbness or weakness, anything like that. Now, oftentimes those things turn out to be just part of the headache and they're not serious, but those are things that you really shouldn't ignore and that you should seek health care as quickly as possible.
Okay. So, Lori, I'm looking at my sheet here. It says you can inherit headaches? They can run in families?
It's very common for especially migraines to run in families. In my own family, there's a strong family history of migraines, and sometimes people get a full headache, sometimes they just get the aura part of the headache, so sometimes people will have a sign that they have before they get the headache, so maybe they'll see flashing lights or something like that. Frequently, when you take a history from someone who has what sounds like a classic migraine, you find out that they have either brothers and sisters or a parent who has, if not the headache, at least the initial sign before the headache.
Okay, great. So we'll certainly get into some of the treatment options, but let's start with non-medical therapies.
One of the most important things that people can do for themselves that are suffering from headaches, again, once they've been diagnosed and once they have figured out that this is, I don't want to say just a headache, but that the headache is the problem, it's not a symptom of something bigger. Healthy living in general is good for people with headaches, and specifically things like taking care of your sleep. People really need to have sleep schedules. They need to avoid caffeine at night. They need to watch their diet, and especially eating late at night before they go to bed. Not watch TV or take work to bed. Really just protect the time that they're in bed and try to get as close to 8 hours of sleep at night as they can. Other things that people can do is watch their diet. There are a lot of common food triggers out there, things and a lot of processed foods like monosodium glutamate, which is in most snack foods, and it's what makes bad food taste good. And it's in the nitrites that are in processed meats that make them last on the shelf for a long time. And alcohol, especially red wine. So trying to avoid common food triggers. And then some people have very weird food triggers, and if you can pay attention and try to keep track of what you ate and when you got a headache to see if there was a correlation. Mm-hmm. There are actually migraine diets that are proposed out there that I'm not a fan of because they are across the board very restrictive, and I think that people eliminate too many things. I personally love to eat, as most people can tell when they see me, and if I had to go on one of these migraine diets, it would take away a quality of life issue for me. So
it'd give you a headache.
It would give me a headache trying to follow it. So I think, but paying attention and being systematic and trying to rule those things out. I think diet and sleep are the two biggest. Exercise is important, but again, if it's one of those things that everyone says is good for you in general, it's probably good for you for your headaches.
Great. Well, we have our first caller. It's Carol from Mingo County. Carol, welcome to Doctors on Call.
Thank you.
Do you have a question?
Yes, I do. My daughter, who is 37 years old, is suffering from hemiplegic migraines. Okay? It's been since January of last year that she began having these. And just last week, she began with seizures. So I'd like to ask the doctor what is the answer to this?
Okay. Well, I don't know if I can give a clear answer. Hemiplegic migraine is a recognized, it's actually one of the most clear-cut genetic types of migraine that does tend to run in families, although there are some forms of it that aren't genetic. And what people complain of is they will develop fairly classic stroke-like symptoms where they'll get numbness in a face or an arm or a leg or all of it, and have a headache associated with that. Oftentimes it is a migraine-like headache. The weakness for most people goes away when the headache gets better, although there are some people that it will continue. With the addition of seizures into the mix, it certainly becomes more concerning. Seizure disorders and migraines do sometimes go hand in hand, that people that have migraine are more likely to have seizures and vice versa. But having a new onset of seizures like that would be one of those things that would be concerning, and you'd want to seek out some care and make sure nothing was new going on, especially if the hemiplegic migraines have been going on for over a year and now the seizures are new. It's probably important to make sure that the seizures aren't something totally different.
Okay, great. We're talking about headaches tonight. If you have a question, please give us a call. Our experts are waiting. Lori, we talked a little bit about behavior modification as a treatment for headaches. Can we talk about biofeedback?
Biofeedback is, so David talked about the dietary stuff. There's other things that you can do. Exercise is sometimes very helpful. Regular exercise, which is another thing that's good for you for other reasons too. But exercise helps in many ways other than just, how we usually think about exercise keeping us fit. There are other things that exercise can do, can release certain hormones that help relax us and also help us regulate our sleep. And biofeedback is another non-invasive way of trying to help your headache. So if your headache is coming on a basis of muscular tension, and we talked about differentiating the types of headaches, and so some headaches will start with a tension headache or muscle tightness, and then it may go into a migraine, which we haven't really defined the difference. So the migraine is usually more like a throbbing headache associated with nausea, vomiting. That's pretty,
Sure.
Yeah. So, and then with biofeedback, so if the tension headache can trigger it, especially, you really want to try to avoid going into that more sickening type of headache. So you can hook up electrodes that read your muscle activity, and then you teach the patient to listen to the sound that's on the screen that's telling you that the muscles are contracting, and then try to make that sound go away. So that's one way of doing biofeedback. Other things that you can do is you can monitor people's body temperature, so try to get them to lower their body temperature. That's also another sign of relaxation. So there's a couple of different approaches to that, and that's obviously a very general description of it. But what you do is, once you train yourself to do that with the machine, then when you start to get the sensation that you're getting a headache, you can do that yourself at home by just.
Interesting.
Yeah.
So, David, what's the most common type of headache? A tension headache?
Tension headache is the most common.
And then migraine headaches is number 2?
Migraine headache is number 2, and it's the most common type of headache that takes people to the doctor.
Okay. So can you help our listeners differentiate between the two? Is there, you said, Lori, that they can sort of melt into each other, but is there a way to really tell the difference?
Well, we try to split these two out, and sometimes I think they're probably really fairly similar. But the things we look for in migraine, in general, it's a headache that's on one side of the head, although that doesn't have to be. It does tend to be a throbbing or pounding, or you can feel your heartbeat in your head kind of pain. Probably the biggest differential in migraine is that people become sensitive to their environment, so lights bother them or loud noises bother them. People oftentimes end up in a dark room. And that movement makes the headache worse. And again, a lot of people will end up being as still as possible, or even going and laying down and taking a nap, because just any kind of activity seems to aggravate the headache. Tension headache is more commonly a headache that's on both sides of the head, either in the front or in the neck. It tends to not have those symptoms, and it tends to not be as bad. So we generally think of tension headache as being a mild to moderate headache, and migraine as being a moderate to severe headache. And so somewhere in the middle there are people that are difficult to differentiate, and that's one of the challenges we have when we see a patient for the first time, is trying to figure out which one is it.
Okay, very good. We have another caller, Susan from Lewis County. Welcome to Doctors on Call.
Thank you.
Do you have a question, Susan?
Yes, I do. I have 2 of them. Since when I start to get a migraine headache, I do a lot of yawning. I wanted to know if that was a common symptom. And I also seem to urinate a lot, if that was a common symptom, and if it was, maybe the migraine was caused from a fluid retention, if that's a symptom.
Interesting.
Yeah, the yawning is actually very common, and it's referred to as a prodrome of migraine, and the idea is that something is going on in the brain well before the pain ever starts, and there's a lot of research going on trying to figure out where it comes from and what is the inciting event. But certainly there are processes in the brain that are different than they normally are, and so people will complain of yawning. They'll complain of being very fatigued or sometimes extremely energetic. People will have food cravings. So there's a lot of kind of those strange symptoms that can, and some people would be very consistent and let them know the headache is coming. Those symptoms can persist into the headache as well. The urination is a similar kind of thing, because you can have the brain stimulate the urge to urinate. I haven't seen people actually have fluid retention and then have urination because they're getting rid of their fluid retention, but it seems like a reasonable thing that could happen. But I think it's probably more of a brain stimulating the urge to go to the bathroom.
Okay, interesting. Our next caller is Karen from Belmont County, Ohio. Karen, welcome to Doctors on Call.
Thank you. Thank you kindly. I actually have a twofold question. I've been getting migraines for between 20 and 30 years now. And now that I am in menopause, I've been in menopause about a year, possibly 2 years now. The migraines, when they come, they last for 3 days. And I'm not quite sure why it's lasting 3 days. And I've had multiple discussions with my physician, and he has alluded to the fact that taking the medication as needed during this 3-day period could be counterproductive. And so I'm a little bit perplexed. I mean, is it something where I should maybe not take the medication that he prescribed and then take Tylenol or ibuprofen, or I'm just a little taken back by that. Can you offer any suggestions or insight to that?
Sure. Karen, what is the medication that you're taking?
I will. I'm sorry, I don't have that handy, okay, but I will get it. I want to say Bubital is what I want to say.
Butalbital.
But you know what? I just renewed it because I just had another episode. Okay. That within a month I had 3 migraines, and they lasted 3 days. I can spell it for you. It's Butal-APAP-325, and then caffeine. Okay. CAFF.
That's an old drug mixture, isn't that, David?
Yes.
Yeah.
It is.
Yeah, that was really, before we knew more and had better treatments for migraines, that was actually one of the more common migraine medications that we gave out. And it worked nicely, partially because it put people to sleep. And you already talked about the fact that if you can lie down and go to sleep, you're going to feel better when you wake up. You go into a quiet environment, everything that bothers you. And there was some thought that the caffeine itself might help. But there's this whole school of thought about overuse syndrome, and that it's actually not treating the actual migraine cause, right, Dave?
Yeah, well, to go back, I think, to the original concern about the menopause and really the change in headache pattern, and then I think get into that, it's very common for headaches to change in menopause. The traditional thinking is that when women get through menopause, their headaches get better. That's actually probably only true about 2/3 of the time, and I have stopped telling women that that's going to happen because there are some angry postmenopausal women who thought they were going to get better and didn't. But because for a lot of women, estrogen fluctuation, especially estrogen decline during their menstrual cycle, is a trigger for headaches. The perimenopausal time can be very challenging because there are a lot more fluctuations in estrogen, and can lead to these more difficult headaches to really get a hold of. And then for many women, then once they complete menopause and their estrogen levels go low and stay low, then their headaches become less frequent. I think what your doctor is talking about is this idea of rebound headache or medication overuse headache, where really any medicine can do it, but there are certain ones that are more likely, and the butalbital medications can, especially the ones that have caffeine. The idea is that if you continue to take medicine, you actually change the way that the headache responds to medicine, and then every time that the medicine starts to wear off, your headache comes back. You may want to talk to your doctor about a newer class of medication. Again, but you definitely want to talk to your doctor about it, because there are reasons why some people can't take the newer drugs, and there may be a reason why you're not on it. But the biggest trick with all of it is to try to catch the headache at the very beginning and try to stop it so that it doesn't continue to be a 3-day headache. Okay,
Karen, good luck with that. We have our next caller is Delana from Raleigh County. Delana, welcome to Doctors on Call.
Well, thank you.
Do you have a question?
Yes, I do. I've had migraines for about 30, 40 years. So anyway, I usually wake up with the headache just starting up. Now, what can I do to stop the migraines when I first catch it coming on?
That's a good question.
So you're waking up with it, though, and it's already there?
Yes.
Yeah. I'm sorry, go ahead.
But if it's like during the day, then I can usually stop it before it comes on. Now, I know if I have chocolate, anything like that, cheese, eggs, all that stuff, I don't eat because that's one of the triggers the migraines.
So you get them when you wake up, but then there's times during the day when they come on also. I mean, there's different approaches to treating headaches. The problem is if you wake up with it, like Dave was saying earlier, if you can catch the headache early enough, if you get a prodrome, that's great. You know you're going to get the headache. You can use some of the treatments. If the headache is already established, so you wake up with it and the headache's there, that's a little more difficult to treat. Many times what we try to do is put people on a preventive medication, depending on how frequently they're getting the headache. So something that you take every day in the hopes that you can keep the headache from coming at least as frequently.
Right. And for people that do tend to wake up with headaches, part of the problem is that pills take a while to work. So if someone is going to use a medication that they have to swallow and get dissolved and then get absorbed, with some of these classes of medications, there are faster ways of getting it in. There are some injectable forms of medication. There are some nasal spray forms of medication that actually get into the bloodstream much quicker, and so it can have a more rapid onset, trying to save a little bit of the time in treating the headaches. But waking up with headaches is one of the challenging things. And the other thing that we would look at is there some reason why you're waking up with headaches? Do you have an underlying sleep disorder? Very commonly, it's people who drink a lot of caffeine. Then the longest time they go without caffeine is through the night, and so they wake up every morning with a caffeine withdrawal headache. And if you're someone who's predisposed towards migraine, caffeine withdrawal headache can then throw you into a migraine headache.
Okay, interesting. Our next caller is Ralph from Vin County. Ralph, welcome to Doctors on Call.
Yes. My question is, what is ice pick migraines and what causes them?
Ice pick migraine and what causes them?
I can answer question number 1. I don't think I can actually answer question number 2 because that's one of those things that we're still trying to sort out. Ice pick headache, and there are a bunch of other terms that have been used for it, things like jabs and jolt headache. The current accepted term, although it'll probably change in a couple of years, is primary stabbing headache. But it's someone who says that they're walking down the street and wham, it feels like someone stabbed a knife in their head or an ice pick in their head. For some people, it's a quick stab, lasts for a few seconds and then goes away. For some people, it's repetitive stabs, and so it's pain that just keeps hitting them for a few minutes. It can change locations. We don't really know why it occurs. It likely has something to do with blood vessels and blood vessel reactivity to some stimulus that's causing them to do this. There's actually an accepted treatment for ice pick headache, which is an old drug called indomethacin, which is an anti-inflammatory that has some specific properties on a chemical that causes blood vessels to dilate to try to keep them from doing that. And so if people have frequent ice pick headaches, I'll sometimes put them on indocin or indomethacin as a preventive, or if they know that there are certain things that will set it off, they can use indomethacin preemptively to try to keep that activity from setting off the headache.
Okay, interesting. Nancy from Lawrence County, Ohio. Nancy, welcome to Doctors on Call.
Hello.
Hi. Do you have a question?
I have a couple of them.
Okay.
I have been diagnosed as having an inoperable brain tumor. And I went to Cleveland Clinic. I have been to several neurosurgeons, several neurologists. No one was able to help me until just recently, which is Cabell Hospital. Been wonderful. I'm having seizures. I had a study. I was in the hospital for a heart cath, and I had a seizure during the heart cath. And I had to woke up, and I had all these echoes in my head. I am feeling this, like putting your head into a light socket. It is like going to the back of my brain, to the front of my brain, down my front, into my arms. It's a horrible sensation. It's like a electrical discharge going off haywire. And I don't know if this is normal to feel this. Okay. It's horrible.
And this happened when you woke up from the heart procedure that you had?
Yes, I had a seizure during the heart cath.
What type of brain tumor do you have, Nancy? Do you know?
Yeah, they don't really know because they can't do a biopsy on it. Okay. They cannot test this in any way.
So Nancy's having headaches or like electrical shocks through her body, is that?
Sometimes it's hard to know exactly what that is. I mean, there are some, sometimes you can get sensations that are, are not really what's happening. So, for example, people feel like there's an electric shock, but obviously no one's shocking you, but it feels like that. Or you feel like somebody's burning you, but obviously no one's burning you. And those are called paresthesias. That's a word that we use to describe them. And we don't know exactly, again, those can be normal, those can be abnormal discharges from nerve. It's hard to know exactly what causes them. Oftentimes the treatment that we use for those are similar to some of the treatments that we use for neuropathies, which are, again, can give you painful discharges from a nerve. I don't think this sounds like a typical headache to me, though, and it sounds like it may be a reaction to something that happened.
And I think you also want to think about what medications that she's on, because there are some medications that can cause you to get these weird
paresthesias, right?
Paresthesias, and especially there's one seizure medicine in particular that can do that. And
which one?
That's a good point.
Topamax or topiramate, and then and there's a cousin called Diamox, which can do the same thing, which is sometimes used for people that have too much pressure in their head, although not usually in someone with a brain tumor type pressure.
Sometimes they use them for unusual seizure types too, so that could be another possibility.
Well, Nancy, we certainly wish you the best of luck with that. We've been talking about headaches with Dr. David Watson and Dr. Lori Gutman. Thank you both for being with us tonight. If you'd like more information, see your family doctor or visit the WVUHealth.com website. For Doctors on Call, I'm Dr. John Phillips. Good night and good health.
Join us again next week for another edition of Doctors on Call. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.